Dr. Vishnu Babu, who has done his MCH plastic surgery from Stanley Medical College, Chennai. He is a consultant plastic surgeon now at the SIMS Hospital, Chennai. He has done his observership in head and neck reconstruction at Tata Memorial Hospital, Mumbai. His special fields of interest are hand and microvascular surgery and head and neck reconstruction. And he is going to talk about the virtual surgical planning for mandibular reconstruction. And we have Dr. K Sridhar, Senior Consultant Plastic Surgeon of ICAP SIMS Hospital, Chennai, who will be moderating this session and taking the event forward. Over to you, Sridhar, sir.
Thank you, Dr. Karthik. I think it's an excellent, innovative session which you have started. I think it is really great going. After Raja Shanmugham's breast, I think we have now come down to the fibula reconstruction. And there are various methods in which I think fibula has been being done. I think one of the best way of planning is virtual planning so that you are more nearer to perfection. I think Vishnu Babu has been passionate about it, which I have been encouraging him to do that. And now he will present to you without wasting time on what he feels about virtual planning in fibula. Vishnu Babu? Yeah, go ahead. I think you are muted. You are muted. You have to unmute.
Yes, sir. Shall I share my screen?
Yes. Yes, Vishnu. Yes, we are able to see.
Okay, sir. Thank you, sir. All right, sir.
Yes.
Go ahead.
Good evening, everyone. Today, I am going to talk about mandibular reconstruction by virtual planning. Before that, I must thank Dr. K sir for giving me the opportunity to present in this forum. As you all know that reconstruction of mandibular defect is a difficult challenge to many of us because it is a complex three-dimensional structure. It has curved, horizontal and vertical portion with bends and angles. What God has given, creating exactly the same is a real challenge. So it is one of the areas of reconstructive surgery where precision in preoperative planning and surgical excision is vastly important. So these are the methods available for mandibular reconstruction, but after Hidalgo's demonstration of utility of free vascularized fibula for mandibular reconstruction when compared to all other vascularized osseous flap, fibula is the workhorse flap for the mandibular reconstruction because it provides 20 to 30 centimeter of thick cortical bone and it has reliable periosteal blood supply. Based on that, you can do either single osteotomy, double osteotomy, even triple osteotomy, and you can manipulate it to any direction and any angle. Even though it has a short vascular pedicle, by discarding the proximal 1/3 of the fibula, you can gain more length and with wide vessel diameter, easy for anastomosis. In case of composite reconstruction, you can include the skin as a single paddle or bipaddle based on the constant middle and lower third perforators. You can also include the FHL muscle in case you want to contour the lower third of the neck. And because of fibula is a long, slender bone, it is more suitable for a 3D optical measuring system, virtual surgery, and to get 3D models. We followed this classification described by Jewer and later modified by Boyd, HCL classification. C stands for central defect from canine to canine, and L stands for lateral defect from canine to the subcondylar region, and H stands for the hemimandibular defect from incisor including the condylar. We find that this is simple and more practical to demonstrate the defect in a standardized fashion, and it also helped us to plan our reconstruction. What are the goals of mandibular reconstruction? Our aim is to achieve form, function, and aesthetics by establishing the mandibular continuity to provide the osseous alveolar base and correcting the soft tissue defects. Thereby, you can able to get desired mandibular function and aesthetics. What are the challenges of mandibular reconstruction? Personally, even I initially struggled a lot to shape and position the fibula, and it all depends upon the surgeon's experience. Because of the mobility of the mandible increases the difficulty in appropriate position of the fibula, especially during conventional surgeries, sometimes may go for dissatisfying occlusion and appearance. Then how to assess the mandibular defect? There are different methods of doing it. Before that, you have to do simple IMF in good dental occlusion if available, because mobility of the mandible will not allow us to take the tumor margin resection, and also you can using it as a teaching material to better understand the 3D view of the tumor for the students. And also you can do mock surgeries on these 3D models, thereby error on the table is very less. And also you can pre-contouring plate on these 3D models, thereby you can have reduce the operative time. And you will get the patient-specific osteotomic guides and patient-specific plates, so that you can get a desired aesthetic reconstruction. So what is virtual planning? It is nothing but planning on the computer by using CT data of the patient craniomaxillofacial skeleton and the lower extremities. By using CAD/CAM technology, you can see the 3D view of the mandible and the fibula. So before planning the tumor resection, we will know the basic idea of the measurements of the mandible and the surface orientation of the fibula. So from angle to canine premolar junction, it is roughly 7 centimeter, and the intercanine junction is roughly 2.5 centimeter, with the angle of 120-degree bend at the canine premolar junction, otherwise called mandibular body curve. And also the ramus of the height is 6 centimeter roughly, with the angle of 115-degree to 120-degree. And I'll show you the small video of how to osteotomize the fibula and surface orientation.
Voice. Voice is not there.
So, voice is not there, sir?
Yeah, now it's okay.
Shall I replay it, sir?
Yeah.
No, or else you can speak on it.
Speak.
Yes, sir. Okay, sir. Now, I used this X-ray template to demonstrate the how to osteotomize the fibula to reconstruct the desired shape of the mandible. So, in this, I'll explain, sir.
இல்லப்பா அந்த இதையே போட்டு பேசுப்பா.
Videos.
அந்த வீடியோ போட்டு பேசு இல்லனா.
இல்ல வால்யூம் or
You talk.
Yes, sir. Now
You talk.
Yes, sir. So to orientation of the fibula, this is the proximal segment and this is the distal segment, and this is the lateral surface. You have the medial surface and posterior surface. On the posterior surface, you get the peroneal vessels. So you imagine that you are planning to reconstruct the central defect, lateral defect, and left side ramus defect. For that, you have to mark the osteotomy on the medial surface. So you have to do closed wedge osteotomy to bend to reconstruct the central portion. So you have to do 120 to get 120-degree bend of the fibula. You have to excise the 60-degree of the triangle on the inferior or the medial surface of the fibula. Then it will rotate horizontally. If you want to reconstruct the ramus or posterior segment, you have to excise wedge excision on the lateral surface. This is another plane. So once you excise that, this will move posteriorly. Now you can see how the segments are moving. By excising here wedge excision of a 60-degree angle, you can get the 120-degree bend, and you have the horizontal portion to reconstruct the central defect, and you will have the lateral defect. Then you have to, if you excise the wedge excision on the lateral surface, this portion will move posteriorly. That is how you have to plan your reconstruction. So with this idea of measurements and angles, I will now we will do the visual planning on this patient. You can see the tumor extension three-dimensionally, both proximally and distally, and in this case the tumor was destroyed the mandibular architect. So as you see, three-dimensional extension, now you have to plan your desired resection margin on the mandible. After once you mark the tumor resection margin, then after tumor resection you will get the defect like this. Most of the cases you have the mandibular arch, so you can use the fibula to superimpose on the lower margin of the mandible to plan your reconstruction. In this case, we don't have the. In this case, the tumor has destroyed the mandibular architect, so we use the mirroring tool to use the fibula for reconstruction. And finally, we reconstruct the mandible. So to confirm your reconstruction, whether it is in good shape and good size and angle, you can overlap on the you can overlap on the arc of the mandible to reconfirm your exact shape of the reconstructed mandible. So finally, you will get the resection margin like this, and you will get the cutting guide for the mandible and the fibula. So what are the advantages of using cutting guides and the cutting guides of the mandible and the fibula, and along with the 3D models? You can use bending of plate over these 3D models, and also it will help to get a near perfect position of the pieces of the fibula, thereby reducing the operative time and ischemia of the flap, and increases the accuracy in mandibular reconstruction. So our method of doing mandibular reconstruction begins with taking CT scan of the cranio-maxillofacial skeleton and the lower extremities. Then the data is saved in the DICOM format and send it to the software engineer. Then we will have a web-based planning session on the computer along with the OMFS surgeon and the surgical oncologist to decide about the tumor resection margin. So now I will show you like this. Now I will show you how we are planning a tumor resection on this small video. This video shows a tumor at the left side body of the mandible. They will show the 3D view of the tumor. We will tell them where to have the exact cut with the margin clearance. Then they will bring the fibula to superimpose on the mandibular arch to reconstruct the mandible using fibular segment according to that, whether it is single osteotomy or double osteotomy. In this case, you see needs two segments with one osteotomy. Once the fibula is reconstructed with the mandible, you can confirm your shape and angle over the superimpose overing the original mandible. So after that, they will send us the cutting guide for the mandible and the fibula along with the 3D models. So once we receive this, we will send it for sterilization to keep it ready to use in the operation theater. So after exposing the tumor, we will fix the mandibular cutting guide then we'll use the oscillating saw to precisely resect the tumor margin given in the slot. Then after that, after harvesting the fibula, we will fix the cutting guide over the fibula, and we will using oscillating power saw and precisely cut the exact angle given in the slots. If you have a defect from condyle to subcondyle to subcondyle, or ramus to condyle, you need longer segments of the fibula bone. To prevent the bone loss, we will do on-table fixation of cutting guide over the fibula, and we will cut first osteotomy itself exactly on the given slot, and also you can save the ischemia time of the flap. So after excision, you can see the precise excision of the triangles of the fibula. So by using these cutting guides, you can see the bone-to-bone precise bone-to-bone contact, and it exactly fitting into the recon plate. In this case, we used osteo-integrated implants also primarily to have early dental rehabilitation. Once everything is getting over, this reconstructed fibula was fixed to the native mandible, and after that vascular anastomosis and wound closure are performed in a standard fashion. So now I will show you some of our cases which we have done. First case, this international patient presented with ameloblastoma of the mandible. After tumor resection, he had a defect from body to the body. So we planned 3 segments of the fibula with 2 osteotomies, and after harvesting fibula, used fibula cutting guide, we osteotomized and fitted and fixed with the recon plate. After fixation with the neomandible, you can see the postoperative X-ray. In this, you can see the precise cut of the fibula and the mandible, which will not be possible with conventional surgeries. And because of freehand marking of the triangles, it may not exactly fit into the recon plate. So you need repeated osteotomies, or you have to use burr to contour to get the more bone contact. So by doing like that, you will be having taking lot of time on table. And this is the post-operative result. Even you can see in this picture, there is a slight overjetting on the left side. Even if you do visual planning, you need experience to get the desired result. So if you see the next case, again ameloblastoma of mandible involving the body of the mandible. After resection of the tumor, again the same defect from body to body. We use the same technique of virtual planning, and using the cutting guide of mandible under the fibula, we resected the fibula. After fixing with mini plates, you can see the post-operative picture. This is the 2-year follow-up. You can see this time we will get very good result. You can see the good chin projection on this, and patient was very happy about the result. And next, you see this patient presented with again ameloblastoma of mandible. He was with this tumor for more than 10 years. He can't heat of he had food difficulties with this tumor. After he came to us, we planned virtually. Again, after and that was the result at the end of the reconstruction. And this was the immediate post-op. You can see even we can did the early dental rehabilitation, and patient was very happy with this result. So with this, I conclude that visual planning allowed us to perform accurate resection and enabling us to precisely osteotomize and reconstruction. And also you can get a very good bone-to-bone contact, and you have a yearly dental rehabilitation with the improved aesthetic contour and reduced complication rate. Thank you. Sir?
Yeah, I think, can I?
Yes,
Yeah,
sir.
thank you. I think it is a lot of hiccups, I think, just like usual virtual planning is required possibly even for this now. I think we have been managing more with manual planning, talking over cell phone and then trying to get the whole thing done. I think it's otherwise, I think it is really good. Now, I would like to tell, number one, is it necessary is a question which many people will ask. It's always an improvement better than what we had. That is the first step I would like to tell. Always we progress by going one step beyond what we normally do. I think that way, this is a step which we can take. There have been questions on this. What are the opportunities for training in oncoplastic surgery in India? I think like the previous lecture and this lecture, I think we must realize there are few centers. Possibly tomorrow you may have to go to Ganga for doing breast. You may have to go to either Apollo or come to us for head and neck. I think it all depends on the number of cases. And one thing like Raja, what he said, I would also like to reassert that when you are doing craniofacial, you must know brain. When you are doing onco reconstruction, you must know oncology. So there's no two questions or two doubts about that. So that way you've got to know your adjoining territory for you to do much better. So that is number one. So you have got to find where you have to go depending upon what exactly you want to do. Maybe Adyar Cancer Institute, they are doing a lot of resections. You may get some fellowship there and go. And then you have to visit outside, possibly for onco reconstruction straight away. Post-specialty training, a stint in a unit. I think Ram has answered that question. Does virtual planning of the mandible take into account the soft tissue as well? I think the question is from Dr. Karthikeyan. Yes, it does take into account.
There is some crosstalk.
Yeah, somebody else has not muted their mic. Yeah, it also takes into account the soft tissue. In case you need to have more extensive study of soft tissue, I think MRI data also will help you. But we have done lot of volume analysis of soft tissues also in this virtual planning. For example, in hemifacial microsomia, we have also done some volume analysis of soft tissue and trying to do for the bone instead of doing for the soft tissue. Because many times we fail in soft tissue reconstruction, hemifacial microsomia. So sometimes what we can do is we can increase the foundation of the malar bone, etc., or the mandible by giving more excess of bone on the side to elevate. That is also a possibility. I think very few questions are there. That's virtual planning for them. Yeah, I think that's the chat questions. I will get back some more. Jitendra Nair has asked, skin paddle always required for mandible reconstruction or just kept for the expected shortage? This is for you, Vishnu. Do you use vein grafts when using fibula for large segment of mandible, usual recipient vessels or facial or superior thyroid? How much does planning add to the cost?
First question, sir. So far, we have never encountered any difficulty in reaching the length because we desired in that way. And this is like benign procedure. We can save the facial artery length. It's not like malignant tumor. In that case, you have to compromise the pedicle length of the facial artery.
No. It is a general question. It is not about benign.
Okay, sir.
So it depends, It depends.
It depends upon the benign or malignant. In case benign, you will.
Yeah, go ahead.
in case of benign, we don't we'll get the adequate facial artery length, so that you can reach to anywhere. In case of malignancy, they will remove the during neck dissection, neck node dissection, they will remove part of the facial artery and they will give only hardly 2 centimeter pedicle vessel length. So still we can able to manage with adequate length to do the anastomosis. So far I never encounter any vein graft for the artery or vein.
Well, it again depends. I would suggest that it all depends upon, supposing the mandible reconstruction is very large.
Yes, sir.
That means the pedicle length is going to be shorter.
Yes, sir.
And then if the neck dissection is very extensive and then you don't have any good length of artery, then possibly we may have to use it. Otherwise, most of the times it is not required. And superior thyroid is also used when you find facial artery is not good.
And
how much does virtual planning add to the cost?
yes, sir. Virtual planning, if you want to get the 3D models of the facial skeleton and reconstruct fibula, it will be cost. But only if you have the cutting guide of the mandible and cutting guide of the fibula, the cost is very less. So it will be you can get some 6,000 to 8,000 rupees between. It will not cost much. And if you see, if you take the operative timing on table, it will reduce almost 1.5 hours to 2 hours. You can have less operative time. So you can compensate on that case, in case if you do as a private practitioner.
Yeah, I think I would like to add here. Number one, you need not have the fibula film. You can reduce the cost on that. You can only take the data from the radiology department. That cuts on some cost. The second cost, as you put it, you don't want a sample of the fibula, then you need only the cutting guide. You don't want to keep a mandible, then you need only cutting guide. But I insist most of the times to have the mandible as a specimen for us to study also further. That will help us. So 6,000 or 8,000 rupees, I think possibly if we have to learn, we can reduce 8,000 from our fees. I think that is the best way of trying to do one step forward. The second one, how much time it takes. Virtual planning, we do it on, it's live. Like, moment we send the data, they receive the data. In a phone call, we fix up an appointment on the same day. We can talk to them and we can plan on the same day. And then it gets delivered within about 48 hours to 72 hours maximum. How do you decide on the choice of plate? Do you use a reconstructive plate or small plates?
We used both, sir. Reconstruction plate is always better when compared to mini plates. But in Tata Memorial, Madam is always claiming that there is no difference between using recon plate or mini plates. Both are equally giving good results.
Do you have an alternative plan if resection margin exceeds your original plan?
That is the advantage of 3D planning, sir. So far, we never encounter, even in malignancies, after receiving biopsy, we never encountered any positive margins, because you can see the three-dimensional extension of the tumor, even in the medullary extension also, which is not possible in 2D view of the CT scans or by seeing patient clinically.
Which saw do you use?
We use oscillating saw with 1 mm thickness. To get the precise cut.
What is the margin of error?
Yes, again it needs a learning curve. I showed in the first case, even my resection, in the first case we used first case also we had small difficulty in getting the good desired shape, but subsequently we learned how to do exact perfect cut. What you have to do, you have to place your osteotomisa exactly given in the angle. That is more important. You should not deviate any angle. Then you will get very good precise osteotomy.
Is caliber match better with facial artery or superior thyroid artery?
Facial artery always little. Facial artery is always matched with the fibular artery when compared to superior thyroid. Superior thyroid artery is a little smaller than fibular artery.
Then primary osseointegration, does it anyway is better with your preoperative planning with virtual planning, or anything is okay?
Yeah, it's an added advantage of even we can plan virtually also where to place your implants, because you can sometimes you will encounter your perforators in between. So to get early rehabilitation, early osseointegrated implant will give better results. Especially patient coming from abroad, this is a better way of doing it, because patient otherwise getting back is also very difficult.
Yeah, I would like to add here is it is more like an osteosynthesis. The absolute contact between the osteotomy site is something which is phenomenally good. The erring margin of the is very good in this. Not that we are not able to do osseointegration otherwise. We used to do even otherwise also osseointegration is being done. And here the only difference is the accurate way you could have seen that there is no gaps at all between. So the osseous integration is much better. Though therefore it is much earlier you are able to get an osseointegrated process is better. One last thing is Joseph Kattadi has given us information which is right. That is, there is an oncoplastic fellowship available for all of you at Tata Memorial Hospital in Kolkata. Now Shivaram has raised his hand.
Yes, sir.
So just one small point here.
Yes, sir.
Somebody was talking about the vessels between facial and superior thyroid. Can I just add my small
Yes, sir.
bit?
Yes, sir. Yes, sir.
In our over 300 cases of fibula flaps, one thing I've learned is it's not the size that matters. The lie matters far more than the size. In any microvascular anastomosis, if I can manage the size very well by various methods, but the lie is extremely crucial. Point number one. Point number two is, quite often in the resection, particularly in malignancy, the oncological surgeons are handling the facial artery. And they will say they've got it right. You never know how much of intimate dissection, how much of damage they've done. Third point is when they leave the pristine superior thyroid untouched. When you lift it, the superior thyroid comes up to meet the facial artery end on straight like that. Whereas your fibula flap, when you put it, your facial artery and fibula flap will meet like this. And that's always a worry. I'm doing all kind of things to make sure that they kind of lie somewhere like this. I turn it around, go around to make sure that I don't get a V shape. It's a nightmare for me if I get a V shape at the anastomosis at the V. I would rather accept a small vessel, big vessel problem. That's not an issue. Lie is crucial. And especially if you don't, if you're a bit unsure about the oncologist's management of the vessel, tell them, yeah, you'll take the facial artery and silently, quietly go and do superior thyroid and be done with it.
Okay.
Thank you. That's a nice input. We have 3 more questions. Do you de-epithelialize the skin for implant for dental rehabilitation?
No, sir. In this case, we didn't do that. But yes, if required, we'll do it. We'll do that.
Does it help in double barrel fibula for mandible reconstruction?
All depends upon how many segment you required for reconstruction. If you have a single segment reconstruction, you can have a double segment for using for reconstruction. If you have larger defect, then it's very difficult to do double barrel. And you can very well manage with the osseointegrated implants and dental rehabilitation.
No, the question is about virtual planning.
Yes, sir.
Does it help in double barrel?
Yes, sir. That's what depends upon the defect size.
As far as virtual planning goes, I think we can bend the fibula whichever way you want, provided you mark the vessel there. In the virtual planning itself, you mark the vessel on the fibula, and then you can try to bend it whichever way you want. It is possible. Even a double barrel, we can.
Sir, one more thing I can tell that always periosteal blood supply, we know the anatomy of the periosteal blood circulation and fibula blood supply, fibular artery. Still, we can plan it double barrel on virtual planning. All you need is anatomical orientation. That's all.
Okay.
Sir, Dr. Selvan has raised his hand. Dr. Selvan, please unmute yourself. You can ask the question.
Where is that? I don't find it.
There is one more question from Dr. Prashant Moon on YouTube on the live stream. The question he has asked is, how do you reconstruct the condyle of mandible if it is excised using the 3D? Does it help?
So far, we never encounter case like that, but there are so many options. The best thing, for my knowledge, what they said, better not to put any implant, because implant complications are very high, especially in case of malignancies. In case of benign, also the main thing is implant complications are very high.
Benign secondarily done implant for the condyle.
Yes.
So there's one more question on chat, sir.
Using superior thyroid may burn bridges. Superior thyroid good for salvage maybe. Facial can be dissected till origin and check flow more often. I don't know who it is. Galaxy, yes. I think Shivram must respond to that.
Sure. The point taken and well appreciated, but the point is, when you look into a large number of series, the number of cases that you need for salvage, for me, it's far more important that my present flap, I guarantee, like as Raja keeps saying, it is very important that you achieve the maximum possible result in your first time. And if that means that I take the best possible available vessel at that time, I would do that. And I would worry about using some other vessel in the neck. I always have the transverse cervical and other vessels. So when it comes to salvage, which is a small number of cases, I will look at other options. But in a present scenario, when I'm doing a case, I'll use the best possible line with the best possible vessel in my first attempt. No compromise on that.
Okay. Now, next question is, any experience with 3D planning and titanium prosthesis? Well, I think I would like to answer this question rather than Vishnu. Yes, we have done titanium prosthesis for TM joint using 3D virtual planning in case where there was actually a trismus which was reconstructed with a fibula, and then the fibula got fused to the temporal bone, and then a trismus resulted again, and then there we have resected that portion, and we have done a titanium TM joint along with the also the temporal bones portion of the joint. We have replaced it, which of course with virtual planning first. We did the planning so that we could measure exactly the amount of height which is required to build. So the glenoid as well as the condyle we could measure, and then the same amount we could resect on table, and then we put in a titanium prosthesis. She is doing really well. How do you overcome the diameter discrepancy? Oh, come, same thing. Glenoid fossa, yes, I think I've written, I think somebody has given me a hint that I missed glenoid. Maybe. I think that's the last question. How do you overcome the diameter discrepancy? Yogesh has asked, Yogesh, but I think, Shivram, I think more questions on you on superior thyroid, I think.
Yeah, yeah. That's the
How do you
topic is
overcome
not
the
the
diameter?
topic was not the choice of vessel, so I don't want to kind of tread on somebody's toes here. But
That's
him
How do
having
you compensate for the
having asked a question, it is not all that different. And I didn't say I use it all the time. If I'm very sure of the handling of the facial, I will use it. But I will, provided there is enough length for it not to form a V. If
No,
I'm
no.
not sure of
Sorry. The question is not that. The question is, how do you overcome the diameter discrepancy?
I saw the question. So I would use it only when these two criteria are not satisfied. But once I use it, the superior thyroid can be dilated enough to be just the right size for the fibular peroneal artery. I don't find that a major problem at all. Up to 50%, you can always manage it anyway, so it's not an issue.
I think that's it, Karthik. I think we are back. I think we had a lot of discussion on it. Anything more? Anybody wants to know about 3D printing? Yes.
Okay.
Oh, back to you, Karthik.
Oh,
Thanks
yes.
a lot for the nice session. I think I must thank you for this effort. Great effort you are doing. I think we are definitely developing the second line. I think that's a great service to the Tamil Nadu Plastic Surgery Group. I think I must congratulate you for that again.
I second that, Karthik, and just a word of encouragement to both our speakers tonight, and both Vishnu, in spite of all the technical hurdles, Vishnu, you're very clear and very measured and slow, a lot of confidence, and Raja, you as well, very nice overview, broad overview of the whole thing. I think with such people around, we'd be very happy that the future line is getting developed, and a little bit more of encouragement from people like Karthik. I think you'll have a great platform, all of you. All the best for you guys.
Thank you, sir. Thank you so much.
Last thing to add, I think two of them have spoken a new dimension in which we can extend our territories. I think that is what is required for plastic surgery. As we shrink somewhere, we have to extend somewhere else.
Absolutely.
I think both Raja and Vishnu has put that point straight. I think we must see more and more of breast reconstruction, more and more of we have 3D printing and further technological innovations to be incorporated into our system. Thank you so much.
Undoubtedly.
Thank you. Thank you so much, sir. Any closing comments from GB, sir? I saw GB, sir, there. And anyway, the whole idea of this program was exactly this, to get more discussions going and to see what the younger generation is going into, what they have set their sights on, so that the seniors can guide them into that properly. And I'm so glad that today again, two potential stars have been introduced to the community, Dr. Raja Shanmugakrishnan and Dr. Vishnu Babu. We thank you, and we thank Dr. Shivaram Bharadwaj and Dr. Sridhar for their excellent inputs. I mean, this is what we wanted. Thank you so much, sir. And I would like to thank all the participants. And before you go, a sneak peek into what is expected next week.